for Global Development. I'm Amanda Glassman. I'm the Chief Operating Officer and a Senior Fellow here in the Global Health Program. We're really proud to host this event that honors the life and work of Philip A. Musgrove. This is an incredible portrait that was painted by our speaker today. He's a true Renaissance man. The World Bank held the last several events, and we're really pleased to partner with Results for Development, Gino Lagomarsino and her colleagues to set up today's event, and with Eleanor Schwartz, Phil's partner, to get this done. So Phil was among the first, what I would call, practicing health economists working in the development field, first as the inaugural advisor on health economics at the Pan American Health Organization with Dr. George Lane, who's here today. And then at the World Bank during the time of the really influential 1993 World Development Report. And that's a report really whose ideas we are still discussing today, and in a way is the seed of some of the ideas on explicit health benefits plans that forms the part of the subject of what Ricardo will talk about later. Phil was one of the principal editors and authors of the Disease Control Priorities Project and of the World Health Report 2000, coining the term more health for the money, used by everybody since then, and especially me. And he was subsequently a deputy editor for global health at Health Affairs. I knew Phil as a friend, mentor, and leader in our field in all things Latin American health systems, and I worked with him and with Ricardo, today's speaker, on the topic of today's talk, setting and delivering on priorities in the real world for universal health coverage. I think UHC has now hit the mainstream as a global health policy goal, but all along in Latin American countries and other parts of the world in the 80s and 90s, they were already using the words universal to describe what they were doing. Phil's work and Ricardo's work pointed out that rhetoric was not reality and that hard choices actually have to be made to deliver on the promise of universal health coverage. Phil's decision tree for public resource allocation in healthcare, I'm sure you've all memorized it, in Chapter 9, of his collected works on health economics and development, copies available here. It's still a very sound, technical, logistical, and implementable way to think about resource allocation. And when I'm in front of a minister of finance or a minister of health, it's still my go-to graphic as a way to understand how to think about priority setting and public spending on health. So that's the spirit of today's presentation. How do we use the framing and tools of health economics to think about and improve on the hard problems and decisions that have to be taken in the real world? In my book, which I got out today, I actually inherited it from a friend, but I discovered that it was dedicated by Phil. And it said, and it's almost like he wrote the words for today, he said, "For you, with the hope that it will be useful and interesting." Dear Phil, take it away, Ricardo.
Do you want to sit here? Thank you so much, Amanda. Give me a second so that I can set this up. Thank you for those words. Thank you also for posting Phil's portrait that I did 4 years ago. I didn't know that you would do that. It was Eleanor's idea. I wanted to tell you how we did it, and it's in plural, because it was a collaboration between Eleanor and myself. Eleanor was Phil's companion. So I decided to paint a portrait of Phil because I was about to do an art show in Washington, D.C. When I'm not working as a health economist, I'm wasting my money as a painter. So Eleanor sent me a few photographs, and I chose one, got her approval, and I painted the first version of it and took a photograph and sent it to Eleanor. And she had a list of comments. The left eye is too big, the lips are too thick, the beard looks too white, the background should be more secondary, and so on and so forth. So I corrected as many as I could, took another photograph, sent it back to Eleanor, and again, she had a list, not as long. And then some of the persistent issues showed up the second time, and I kept working on them until at one point she said, "That's it, that's Phil." So that was a great thing to do. She has the original. I'm honored to be here remembering my best friend and colleague, Phil Musgrove. I want to thank Eleanor Schwartz, Phil's companion, for her drive and hard work to make this event possible. I also thank the Center for Global Development for hosting this memorial lecture and its Chief Operating Officer, Amanda Glassman. Amanda and I arrived, where's Amanda? There. Amanda and I arrived in Buenos Aires the day after Phil's tragic death, knowing already that Phil would not be at the meeting where we were supposed to work together. Gina Lagomarsino, President and CEO of Results for Development, was also instrumental in making this event possible. Thank you, Gina. I also thank my former boss, colleague, and friend, Marty Mäkinen, Executive Vice President of Results for Development, for his willingness to be a discussant of my presentation. Thank you all for coming to this event today. I'm surprised and a little bit in shock to recognize so many of you. And to realize that it's been 35 years since I've been doing this. A long time has passed, and with many of you, I've worked in a bunch of countries on different subjects, so it's wonderful to have you all here. Phil was a lucid and passionate health economist who made an indelible contribution to our field. He was a highly respected reference point on technical matters. He was never shy to express any of his dissenting views on matters of international health policy and help us all remain technically consistent in our work. Our field and what we do are stronger because of his existence, but weaker since his absence. WHO defines universal health coverage as ensuring that all people have access to needed promotive, preventive, curative, and rehabilitative health services of sufficient quality to be effective, while also ensuring that people do not suffer financial hardship when paying for these services. Universal health coverage has therefore become a major goal for health reform in many countries and a priority objective of WHO. In many developing countries, health benefits packages stand at the center of universal health coverage policy. Their design and implementation give rise to several policy and implementation challenges. Offering sound advice is essential. Human, physical, and financial resources are limited in the health sector and in other sectors as well. This is a fact that all countries face, not only poor countries. The scarcity of resources has led some countries to establish health priorities to the definition of a health benefits package, which I will refer to through the acronym HBP. An HBP is a subset of all possible healthcare services that exist. Defining the contents of an HBP is challenging on technical and political grounds. But that is only the beginning of the many challenges that follow in relation to the planning, implementation, and evaluation of the impact of health benefits packages. I want to talk about the central role of HBPs in UHC policy. As the figure shows, HBPs are at the center of UHC policies. However, not all countries have an HBP. In those that do not have one, there are patient queues, or there is poor quality of services, or there's demand deflection by providers. And these become implicit rationing mechanisms that limit healthcare access for all citizens. These supply and demand constraints configure some sort of implicit health benefits package. Many challenges arise in the context of HBPs. In this presentation, I will cover only 6 of them. I will therefore leave many important challenges out. For example, I will not talk about the equity implications of HBP policies, and I will not talk about contracting and payment methods for benefits packages. Not because they're unimportant, but because I have limited time, and I too need to ration what I present. These are the challenges I'll talk about. Setting priorities, the challenge of constructing an HBP. Preserving an emphasis on public goods. Estimating the resource needs and the costs of a health benefits package. Financing an HBP. I will talk about the informal sector. I will also talk about the miraculous conversion of out-of-pocket spending into prepayment. And I will talk about budget shares to reflect priorities. Then I will discuss the issue of political pressures toward expanding health benefits package beyond the imaginary. And the last point is the need to rely on an efficient healthcare delivery system to have an effective HBP and UHC policy. In terms of setting priorities for health, many tools have been produced by development organizations to help countries construct HBP. For example, the Center for Global Development, through the books produced by Amanda Glassman and her colleagues, are helping to advance knowledge and the use of practical techniques in the area of health benefit packages. I encourage you to read the latest book they published, What's In, What's Out, Designing Benefits for Universal Health Coverage. I'm a co-author, and I do get a kickback for each copy that you purchase. The Joint Learning Network also put out very useful tools related to health benefit packages. These are some of the countries where I have worked on the subject of benefit packages and priority setting. So there are several in Africa, in Asia, and in Latin America. I very much hope that there are no experts on any of these countries in the audience and that you will not ask any difficult questions about them. I want to present a framework here to talk about priorities in health. Phil Musgrove proposed this conceptual scheme to think about the role of government and the role of the private sector in health. So health services can be purely private, that's along the horizontal axis, when consumption only benefits the individual patient, or they can be purely public, there at the bottom left. And when they're public, they benefit the patient and everybody else in society. Or health services can be mixed, somewhere in the middle there. Along the vertical axis is the production cost of a service, from very low to very high. Health services can be very costly to produce, such as cardiovascular surgery, which would be at the top, and emergency care for trauma, or they can have a low production cost, such as oral rehydration salts. So Phil, by combining these two dimensions, the nature of the good and the cost of production, he set out this plane that essentially defines 3 main areas: low cost, mostly private health services, catastrophically costly private services, and then on the left, public health goods. Countries wishing to define a benefits package typically spend time and energy deciding which services should belong in the package. For example, I recently did work in the Republic of Congo, where they decided to have some low-cost services that have a lot of externalities, some low-cost private services, and also they decided to include in the package some catastrophically costly health services. But they spent a lot of time discussing what should go in each of these subsets, especially up here, which catastrophically costly services should be in the package. So how to select which to put where is a challenge where countries do need a lot of help, even today, even after all the time that has passed since these subjects were introduced. Another subject is that some countries decide to include services in the package which their policymakers and technicians believe are good services for everyone, but that people do not think so. So they do not demand those services, and that continues to happen at a high frequency rate. Lots of services, including in a benefits package, which people do not want to demand. That happens to some preventive services for HIV/AIDS. It happens to many other services, including the ones that I saw in the Republic of Congo. In Peru, defining a health benefit package they defined a package known as PEAS, which stands for Essential Health Insurance Plan. But this led to a confrontation between the Ministry of Health and the Ministry of Finance. It was a heated debate. Amanda was there at the time working with me on it. Doctors wanted to include in this PEAS package everything under the sun, because doctors are not trained to think too well about priorities. The Ministry of Finance wanted to include only those services that were cost-effective and that the budget could afford. The Ministry of Health won the debate, and a large PEAS was defined. It was about that big. In practice, financing remains insufficient to pay for this large benefits package, and therefore there is implicit rationing of these services. That is a situation that I continue to see in way too many countries, benefits packages that countries simply cannot afford, and one wonders, why did they define it? Why did they make it so big? But what about public goods that are on the left there? What about these? Around 1993, Amanda was reminding us, Phil had a heated debate at the World Bank with another health economist about public health goods And it was at the time that the World Health Report, report was about to be, World Development Report was about to be published. It was called Investing in Health. The debate was, among other things, around the criteria that should be used to select which public health interventions should go in a benefits package. And Phil argued that cost effectiveness was the right criteria for public goods. But there was a lot of discrepancy regarding what criteria to use for services that were not public goods. By the way, the debate became a public good because everyone in our field knew about it. We were copied on all messages going back and forth. So India is a country which shows under provision of public goods. This is shown in the figure with India is shown in the yellow bar there with data on infant and maternal mortality and coverage of sanitation facilities for selected Asian countries. Countries are sorted in ascending order of per capita GDP, so the poorest is there on the left, the richest is on the right. In India, there's a very low provision of sanitation services, the lowest of all these countries. Only about 40% of the population in India has access to sanitation services, and this limited access results in diseases that affect especially pregnant women, mothers, and children. Vietnam, which is here right next to India, it has the same per capita GDP, but it has a much higher provision of sanitation services, and it has much lower infant and maternal mortality than India. Therefore, efforts in India to define the benefits package should necessarily be accompanied by concrete initiatives to improve the coverage of sanitation. But policymakers in India do not seem to perceive that as a priority. In Chile, overweight and obesity have experienced a steep increase over the past 10 years. That's morbid obesity. This is total obesity. I believe there is under-provision of public goods to prevent or combat obesity in Chile, and as a consequence, a lot of money is being spent in that country to pay for curative health interventions that are required to deal with the consequences of obesity. The pie here on the right highlights in brown the health services that are in part a consequence of obesity: diabetes, hypertension, end-stage renal disease, depression in adolescents, stroke. Nearly half of the money that Chile spends on its health benefits package known as HIS is money going into curative interventions which are caused in part by obesity. But if you look at what the country is doing to combat obesity, it is very little. Costing of HBPs and financial feasibility. Costing an HBP is a key part of the prioritization exercise to define the contents of it. The question is, will public and private resources suffice to pay for the costs of delivering the services contained in the HBP? How much money will be left to pay for health services outside of the HBP? There's an impressive set of tools that have been developed and made available to developing countries to assess resource needs and costs of various health services for different target groups. Some of the tools help the user determine the needs for and expected cost of human resources, physical infrastructure, drugs, and medical supplies needed to deliver a health benefits package. Tools designed to deal with a broad range of services are shown there on the left, whereas tools designed to deal with specific sets of services are shown on the right. As you can see, there is not a lack of tools to figure out what might be the cost of a package. But most of these tools have limitations that restrict their usefulness. I have tried to use many of them. They use standard production functions when in reality production does not conform to standards in countries. Further, they pose huge data requirements to populate them. Most importantly, it is very hard for the users of these tools to interpret the results they get. This is something I find time and time again. Countries spend months populating one of these models. They press the button and compute the cost of the benefits package, and they say, okay, $21.52 per citizen per year. What next? Is that too much? Is that too little? Is it feasible? What does it mean? So the models compute the standard cost of production assuming certain rates of delivery or coverage, for example, 40%, 45%, 50, 55, 60, and compute the cost based on those rates. Most of the countries where I work want to compute the cost of delivering at a 100% coverage. So you ask, how long is it going to take you to get there? 2-3 years at most, when in fact you know that it's going to take decades for them to reach that point. So computing the cost at full coverage doesn't have much of a meaning. It's not very helpful. Further, because costing is based on standard production functions, the cost computed at, say, 40% of coverage here will be different from what countries are actually spending on the production of the services. This is a cost, assuming that all doctors are there, that all drugs are there, that the physical infrastructure is there. What countries are spending is a lot less because they don't have all the doctors or all the drugs, etc. So countries do not know how much they're spending on priority services or how much they're spending on non-priority services, and they don't know what would be the gap to be able to produce services at 40% coverage, meeting the standard. So you can spend a lot of time and effort using many of these tools, and at the end, the result that you get is very hard to interpret. It is of very limited usefulness. So how much money will be required to make progress towards UHC? I think that by using these tools, most of the times you just don't know. I have found it useful to work with national health accounts to try to answer some of these questions. But national health accounts do not disaggregate services enough to be able to make a link between national health accounts and the costs estimated by these models. But it's a very good first step. I encourage you to do that, and this highlights the importance of national health accounts. Let's talk about financing now. A common and wrong assumption is that households will readily convert their out-of-pocket spending on health into health insurance premiums. So that's out-of-pocket spending. And then some people say, no problem. People are already spending a lot of money out-of-pocket on health services. Let's take advantage of that money and convert it into a voluntary prepayment. 10 times wrong. This is I have read many prominent technical reports that lead the reader to believe what is blatantly wrong, that patients can easily be induced to take their money that they would have paid out of pocket and paid voluntarily as a premium. It will lead policymakers to believe that universal health coverage can easily be made financially feasible, when in reality that is not the case. To get people to prepay is a completely different business. It calls for completely different policy interventions, and it takes a long time. Let's talk about the evolution of budget shares. Effective implementation of universal health coverage policy implies in most cases that the proportion of the budget going to pay for priority services is going to grow over time, since they are priority services. So this is a situation where, with time, if the implementation of the reform is done here, you would expect that the proportion of the budget going to the priority services is growing because they're priorities. So you would expect that A divided by B is going to be less than C divided by D. C is the proportion going to priority services after 3, 5, 10 years. I haven't seen a report that shows this. Maybe this has happened, but I haven't seen a report that demonstrates this. But I have seen at least one study that shows that in the country where I live, Chile, the budget shares remain constant 5 years into the reform. These were priority services that were underprovided. 5 years into the reform, we found that A divided by B was the same as C divided by D. What happened? Why is it that after the reform, the same proportion of the budget kept going to priority and not priority services? Well, what happened is that the population got used to the idea that they had guarantees to access this. So they exerted pressure on politicians to get guarantees to obtain this as well. And politicians, therefore, have been dealing with political pressures to make everything a priority, when in fact it can't be done. So these are the empirical data from Chile. These are spending on priority services before the reform, spending on non-priority services. You can see that 5 years into the reform, the shares remain identical. Despite abundant evidence to the contrary, many countries' policymakers and some of their advisors believe that substantial financing will be collected from informal workers to pay for UHC. In middle and low-income countries, the informal sector represents a large proportion of the workforce and population. A significant share of informal sector families are non-poor. Since they're non-poor, this leads policymakers and some consultants, I'm afraid, to the wrong prescription. Since they are not poor, we must get them to pay for their HPP coverage. These are countries where I have worked, where they have tried to get the informal sector workers to join social health insurance voluntarily or forced by the law. Every one of them has actually failed. They have not, even the US in the 90s, tried to get the informal sector workers to enroll in a health insurance system, even by subsidizing with federal funds and state funds 80% of the premium, and still they wouldn't get informal workers to join health insurance. Yet lots of consultant reports say, not a problem, informal sector workers, most of them are non-poor, get them to pay, and that will allow you to advance more quickly towards universal health coverage. So in practice, what happens is that lots of subsidies are required to enroll these different population groups to eventually have insurance. Countries that have achieved full coverage, such as Japan, Austria, Colombia, Chile, Costa Rica, know that it takes a lot of public financing to be able to enroll the informal sector. Let's talk now about fiscal balance. Too often policymakers choose to expand nominally the contents of the package to gain popularity, even in the absence of additional financing. I remember the political campaign 2 governments ago. So the guy from the right said in Chile, we will increase the contents of the benefits package from 80 to 100. There you go. And then the candidate from the left said, that's nothing. We will increase the contents of the package from 80 to 120. How about that? It was the candidate from the left who won, and actually she didn't make any changes. She won, so that was a good speech, but then she realized she didn't have the funds to expand the contents of the package. So this is the famous coverage cube. You would expect that coverage would be expanded gradually as more resources become available. Let's look at the situation of Plan Nacer, and I'm going to be finished very shortly. Argentina's Plan Nacer, which was renamed Sumar, is an example of this practice. In its beginning, Plan Nacer set out to deliver a very narrow, well-prioritized benefits package for low-income mothers and children. Initially, it was thoroughly evaluated and showed positive results. Regretfully, political pressures led to an expansion in the contents of the package to the point that it currently contains several hundred interventions. Public financing for them is obviously insufficient. This is no longer a feasible and a prioritized benefits package. It's more of the same fallacy, all services for all citizens. It sounds good, but it's not delivered. Phil Musgrove, by the way, did a lot of work on Plan Nacer. Well, fortunately, he didn't get to see this expansion in benefits. He would have been mad. I can only imagine his face and his reaction. Chile has set a fiscal rule to try to avoid a situation like the one I just showed, only with limited success. So The Ministry of Finance participated in the definition of the benefits package there, and they included a law that would limit how much the package can cost each year. And that limit would be an index related to real salaries in the economy. Accordingly, the number of medical problems in the package has grown only progressively and cautiously from 25, 10 years ago, to 80. But even then, thanks to this rule, the number of services contained in the package has been limited, but even then, there are growing waiting lines for the services that are in the benefits package in the public sector. They're getting bigger and bigger. So even if you manage to be fiscally conservative, you may find yourself facing growing queues for your guaranteed services. Finally, to be successful, universal health coverage must rely on an effective and an efficient healthcare delivery system, but that is a rare species. This is from recent work that I did in the Republic of Congo. On average, basic pharmaceuticals in the Republic of Congo cost 4 times as much as the international price. 4 times as much. So if you compute the expected cost of their benefits package using the real price, you get a cost per citizen of $27 a year. If in Congo they managed to have an efficient pharmaceutical sector and prices were the same as international prices, the per capita cost of the benefits package would only be $12.4, half. So countries can spend a lot of time and effort defining priorities, but if they do not fix the underlying functioning of the health sector, it's going to be a limited exercise. In Mexico, the reform known as Seguro Popular was implemented in the early 2000s to improve coverage, equity, financial protection, and health status for the poor. Between 2000 and 2010, the difference in per capita financing between those with Social Security and those without was 2.1. So those with Social Security were getting twice as many resources as those without. 10 years later, thanks to this reform, the difference was a lot smaller. People with Social Security and without were receiving nearly the same amount of money. Yet, what explains that out-of-pocket spending, which was 50% 10 years ago, remained almost unchanged 10 years later, despite all this money being pumped into the health system? So Felicia Knowles, who is one of the authors and key researchers of the reform, said, until universal access includes a guaranteed acceptable level of quality, the egalitarian exercise of the right to protection of health will remain an elusive goal and inefficient out-of-spending will grow. Without efficient use of current resources, generating the additional fiscal space required to face the burden of chronic diseases is politically infeasible. Out-of-pocket spending persists, along reductions in the prevalence of catastrophic spending because families continue to face issues with quality and with access. Gaps in access persist because of continuous limitations in crucial healthcare inputs, especially human and organizational resources. Let me conclude very simply because Marty is going to conclude for us. In many developing countries, universal health coverage policies rely on the definition and the implementation of a health benefits package. In addition to generally higher levels of public spending, defining and implementing an HBP calls for broad technical knowledge and experience, which many countries lack. Developing agencies have access to such a knowledge and offer it to some of their recipients. However, much remains to be done among developing agencies in terms of generating evidence and good practices. Further strengthening health systems remains an indispensable action if UHC ought to succeed. So this presentation has pointed to some of the technical areas where further knowledge and development assistance are badly needed. Thank you all again. I encourage us all to remain keenly analytical and logical in the work that we do, and to base our advice on empirical evidence. Thank you all, and thank you, Phil, for teaching us all these tools.
I'm here to prevent a Mannal. A Mannal is a panel of only men. But now, Marty, take us away. You've also worked a long time in these issues.
Okay, so thanks, Amanda. Thanks to the Center for Global Development for hosting this event. And thanks for letting me be a part of honoring the memory of Phil Musgrove, and also in joining with my old friend and colleague, Ricardo. I, of course, always learn a lot from Ricardo when he speaks, just as I learned a lot from Phil every time he spoke. And as I mentioned to some of you as we were mingling before the event, that I learned a lot from Phil, not only when he spoke, but also when he asked questions. And he always asked questions that had messages in them, and were provocative and a little bit on the grouchy side when he saw things that he thought didn't meet the criteria that Ricardo just mentioned to us. So, and also I'm grateful that Results for Development Institute is a part of this event as well. The focus of Ricardo's presentation on health benefits packages is very timely. Earlier today, I and some of my colleagues who are sitting here in the audience participated in a joint learning network webinar that focused on health benefits policy. And the JLN countries that are involved in a collaborative on health benefits policy include Indonesia, Kenya, Malaysia, Mali, Morocco, and Vietnam. And Ricardo has been an expert advisor to that collaborative. And that collaborative began its work around a shared interest in applying and working with and developing or amending health benefits packages. But after some initial discussions among the countries and the technical facilitators, that group made a shift in its focus from health benefits packages to health benefits policy, and Ricardo was a part of this. And this somewhat subtle shift in label from packages to policy reflects the collaborative participants' recognition that to be successful in achieving the objectives of defining a benefits package, the definition needs to be, the definition of the package needs to be complemented by efforts in a number of complementary domains. Okay? And those domains that were identified by the collaborative members include supply readiness, payment mechanisms, accountability systems, including monitoring and evaluation, adequate financing, clinical protocols and pathways, and adequate efforts to stimulate demand and the use of the services in the package. And the collaborative also identified a set of commonly shared objective areas for health benefits policy that include the ones that will be familiar: equity, financial protection, health outcomes, quality, efficiency, and sustainability. But the priority among those different objectives is expected to be different between countries, that each country would share probably at least largely that set of objective categories, but give each of them different priorities. Ricardo mentioned, and it's important to remember, the World Development Report of 1993, Investing in Health, because that's one of, if not the first mention of the concept of health benefits packages and recommendation. It was strongly recommended by that report. And of course, Phil was one of the authors of that World Development Report. And I went back and looked at it again for a number of things, but also noted that my memory wasn't completely faulty, that Ricardo also contributed to that by being one of the members of many consultative meetings that the World Bank held around the development of that report. And that report called for an essential package of services, so its name has changed slightly over time, to be funded by governments. And what the World Development Report said at that time was that using an essential benefits package would reduce the disease burden of low-income countries, and made it the global estimate, by 24%. It's not saying every country would reduce its burden of disease by 24%, but globally that was the estimate at that time. However, I also looked around to see whether there were any evaluations that would evaluate health benefits packages against that objective of reducing the burden of disease. And I didn't find any. Maybe there are some out there, but nothing that I found could show it systematically and carefully done that health benefits package policy implemented, and maybe it's because it's never been completely implemented, what impact it has had on the burden of disease. Okay? So, but many countries, 26 years later, continue to pursue essential or basic packages of services as a policy, and as Ricardo said, as the centerpiece of their universal health coverage policies in pursuit of achieving universal health coverage. So it must be a valuable concept, even if it hasn't necessarily been backed up by evidence of its effectiveness. And as, if I channel a little bit of Phil here, might say, well, things should be based on evidence, but the fact that countries are using the health benefits policy might show that, on the one hand, that it does have merit, or it might be a way for country policymakers to hide behind using that concept to continue business as usual, which a little bit of the data and the findings that Ricardo showed us about shares of spending on non-basic package services give us. So I don't know where the truth lies, but we should think about that. I also agree with a number of the points that Ricardo made. One is that public health interventions are often ignored or given a low priority compared to personal or individual health services, and that's an error, and his data from India shows that very carefully. And the argument might be made that public health interventions should have as high a priority or higher priority than the personal services included in an essential health package. And looking back at the WDR of 1993, it actually made that point and said an essential health package should begin with public health interventions. But that's been lost in the time since, where the focus has been on individual services and personal health services over time. And of course, it's important to remember that a public good is a product that one individual can consume without reducing its availability to another individual, and from which no one is excluded. And because we have the term public health, it's sometimes personal services are sometimes put in the category of public health services, and what we're talking about are public good health services. Ones like water supply and sanitation, disease surveillance and response, health education, and health behavior information, which are the kinds of things that are not consumed by individuals and can be provided to all, like information about prevention of hypertension and diabetes and other chronic diseases that Ricardo mentioned have become such a big part of the burden of disease in Chile and many other countries today. Also agree with Ricardo that the cost information produced on the development of benefits packages is inadequate. All of the points that he made about interpretation, about the use, about making the information more dynamic is rarely done and done not so well when it is done. But I do like the methods that he mentioned that Chile has used to make explicit finding the additional funding before adding services to a benefits package, even though it's imperfect in its results. It's one of the better results that we have, so we shouldn't throw it out just because it's imperfect. I also agree with some of the things that Ricardo identified as persistent myths or wishful thinking, and I think he was channeling a little bit of Phil again on those kinds of things, because those are the kinds of things that Phil would like to bring up, that households are not ready and willing to convert their out-of-pocket spending into health insurance premiums, and that when governments increase their spending on health, they also can't count on a dollar-for-dollar decrease in out-of-pocket spending, but they can help decrease out-of-pocket spending. And one survey that we helped analyze in Ghana found that families spent more on health out-of-pocket after they were insured by Ghana's national health insurance system. It's also not at all easy to collect insurance premiums from those in informal employment, whether it's on a voluntary or supposedly mandatory basis. And this is especially the case for the non-professional informally employed, and governments should definitely stop thinking that this will work, and consultants should stop saying that it might. And of course, greater efficiency in the delivery of health services can be easily obtained. The idea that efficiency of the delivery of health services can be attained easily through administrative measures or management measures alone is another myth. But I want to add a few things to Ricardo's list. Another one is that quality can be attained and sustained at scale by training human resources in quality improvement. The decades-long efforts in this direction have rarely, if ever, reached scale or been sustainable. We have the evidence. Let's stop believing in that. Also, the notion that financing of healthcare should be largely contributory rather than funded by government revenues, general revenues. The struggles to get contributions from individuals and families cost a lot and then result in less than complete contributions and many political questions about the fairness of all the methods that are used. The overall taxation system is likely to be no costlier, since it already exists, and has an accepted degree of fairness, whether it's fair or not. So much more emphasis should be placed on using general government revenues instead of working on various schemes to extract individual contributions. Last myth or wishful thinking that I'd like to put out there is that central pharmaceutical stores are more efficient than commercial wholesalers and can be made corruption-free through better training, management, and software. We also have decades of experience of putting together or reassembling central government-run medical stores that fail and become corrupted over and over again to the detriment of efficiency. I wouldn't be surprised if some of those differences in pharmaceutical prices that Ricardo showed for Congo Republic are due to such a system, or a large part could be attributed to that, but we keep doing it over and over again. So with that, I want to congratulate Ricardo on teaching me many lessons again today. I want to, again, remember Phil Musgrove for being someone who always stimulated us and provoked us to think differently, and I hope I channeled a little bit of him, but I know that he would have critiques of some of the things, if not all of the things that I said too. So thanks very much.
Thanks, Marty. All right, So I
Thank you,
think
sir.
the point you started with was really important, which is that a benefits package, a list of services on its own, is not a very meaningful priority-setting tool. And I think the points that you're highlighting also speak to that reality. So it's about the surrounding set of policies that translate a list to something that is delivered in practice. That said, without the list, maybe you don't have much at all. And that's the whole insight from implicit rationing to explicit rationing. It's very hard, though, to convince policymakers and governments that explicit rationing is necessary because it's painful and it involves making decisions about things that are going to have a lot of high stakes, a lot of economic interests around it. And so that's why I really like the Chilean example, because it's not saying none of the other stuff will be provided. It's saying at least this done well at coverage, and the rest will muddle through. That allows the politicians to have somewhat of an out, although what you're describing is that they are, because it worked so well. Actually, Ricardo has a very nice evaluation. It's not a randomized control trial, but it's a really good evaluation that looks at the impact of Chile's GES on case fatality rates, on hospitalizations, on detection rates of things that were under-detected before. I was actually very impressed by the results of that study. It's influenced a lot of the way I think about these issues. But even so, do you feel like we're better off now in a Chile kind of world? And should other countries be thinking more about the Chile experience with all its difficulties and problems than a country, for example, like Colombia, that was trying to do an exhaustive list of everything, running into constant political problems, and in the end, they've reverted to implicit rationing in some ways. So what's your view on that?
Well, even though I was not the author of the Chilean Reform, I do think it's a very good one. It has produced very significant results. I am appalled that despite all its achievements, it hasn't been evaluated thoroughly, and the information that has been accumulated about it and about its good results hasn't been disseminated, because it will be very helpful for Chile and for many other countries. I think that the exercise of defining priorities and then trying to configure the system in a way that it will be able to deliver those priorities and to have the resources for that, I think is a good, valuable exercise. But I think that many countries get lost early on in that process. It remains useful to do, and I think it's good that countries are doing it, because for the first time they're making explicit the need for financing. They're recognizing that they're not meeting demand for basic services, that there are quality problems, that there's high out-of-pocket, and at least it tries to focus those policies on a subset of important services. That's better than trying to focus that same amount of energy on all the services.
And what do you think, Marty? I mean, so you're suggesting, I mean, I would say there is empirical evidence that some of these kinds of policies work to deliver some set of care. You've pointed out that a lot of the insurance arrangements are only covering these high-cost personal products. Those are services that were in that top right-hand quadrant of Ricardo/Phil's graphic. So a scheme like RSBY, for example, always was doing, they actually restricted reimbursement going to private primary health care centers, for example, because they said, oh, that's going to be covered by the central government through the National Health Mission. I mean, what is the incentive? I mean, it seems to me like there's a political economy problem. You would have to take the PHC money from the National Health Mission in India and give it to the insurance mechanism, which is paying in a different way. I mean, how feasible is this to do in reality? It's a little bit the same in Indonesia, right? It's a popular thing to do, to reimburse secondary and tertiary care and to leave PHC and public health to the public sector, to the subnational government, or to things like that. How do we get out of that?
Well, I don't know that there is an easy way out of it, but that is a very big issue, is how do you change from the status quo to a new mechanism? But I think that the continued interest in health benefits packages and health benefits policy. And I think the extension that the JLN Collaborative is making is a very important step to look more broadly at it, are ways to stimulate the thinking of a number of countries so that some will take this on and do it in different ways. And we know that Ghana is now rethinking its essentially we'll cover everything with our system when they ran into severe financial problems to it looks like they're going to focus on the primary care services through their system. So maybe Ghana will be one of those that will show the way. But I think it's also really important that we, as a global community, ensure that whatever efforts are made in these directions get the kind of evaluation, documentation that can allow the results to be disseminated, whether they work or they don't work. So the successes and even the failures of Chile do need to be better documented so that others can learn from them. I'm a big promoter of some of the notions, the guarantee notion, the linking of the financial ability with the adding of services, the starting small, moving bigger, but it would be nice to have more evidence to back that up when I'm advising others. So as Ghana or others start with the primary care focus for their package, we need to be there to help them evaluate it, document it, both so that they can fix any problems with it, but so that others can learn as well.
I mean, was Phil asking for too much when he said, first primary care, and prevention? Because, as you said, many people don't demand those services, right? And it's not what anyone thinks of when they think of insurance, right? They want to be able to be covered if they break an arm or they have appendicitis and they have to go to the hospital. In very resource-constrained settings, it's almost an impossible choice that we're asking countries to make. I mean, are we right to ask that? How could we, is it really just a question of waiting till you get a little bit richer to be able to make less terrible choices? Or what's the role of donors, for example? All right, we'll go to the audience. Think it over. Anyone?
Also, the status quo is that many of those things are only available to an elite.
Right.
So leaving things as they are is not a solution either. Mm-hmm. And donor resources can't make that much difference. Yeah. Even if all donor resources were to go to the catastrophic care for all, they wouldn't go very far, and we'd be only in a small sliver of that because the donor resources just aren't that much compared to the national and domestic resources. Mm-hmm. So it could do that, but it still wouldn't make much difference.
I think when you look at a country like Thailand, these are countries that actually started with very modest budgets and were a bit ruthless about priority setting, but they also allowed some things, because they had a process in place that would allow them to include some higher cost, highly demanded services at the same time. On the other hand, we could talk about the form of government that allowed them to do that. But can you think of an example of a country, maybe it will be Ghana. I don't know. What do you think? I also read, for example, that in Ghana today they made some deal, a $300 million new private hospital is being built in Accra. And I asked myself, how soon till the National Health Insurance Service is going to be asked to reimburse procedures there? Because all of a sudden, you're going to have the capability to do a lot more in terms of your resolutive capacity. You'll know what kids are sick and you could treat them there. We see that kind of trade-off happening all the time. Yeah. Go ahead.
I remember Phil talking about the work of a medical anthropologist who explained what were the reasons that people sought medical care. And I don't remember all the reasons. He would, but I don't. But one of them was fear, anxiety, ignorance, pain was another one. I think that the human nature is such that a society is driven to complain about a system not delivering pediatric cancer care, say treatment for children with leukemia, and that same society is less motivated to complain that not enough antibiotics are available for pneumonia for some reason. And I think that politicians know that, and that produces what I think is a perverse shift in priorities of public policies. And that is what lead Ghana policymakers and those in many other countries to actually build tertiary hospitals that do deliver cardiac surgery and pediatric surgery for children with cancer and so on. One of the early experiences I had working as a health economist was for the IDB. I remember going to Barbados. It really taught me a lesson. I went to Barbados and had to do an overall health sector review. It was a small country, and I was an apprentice. I don't think I did a good job, but one of my conclusions was that this large tertiary hospital in the country was eating up about half of the country's budget. And much of the money went to pay for cardiovascular surgery, especially bypass surgery. And I also noticed that the people of Barbados tended to be on the heavy side. So my advice to the government was that more money should go into prevention of obesity and less money toward tertiary care. And so I finished with that brilliant sentence, my report, and I submitted it to the Minister of Health and her advisors. And while they were reading my one-page summary, I realized that they were all heavy and that they were not looking happy as I read. So they finished, and the minister looks at me and says, Mr. Bertrand, do you realize that we in this room will need to go to that ward very soon? So your recommendation is not feasible. I said, I apologize, thank you. But that did teach me a lesson. For some reason, people behave in such ways and think in such ways that tertiary care becomes a priority for individuals. But society, there's a failure in the way society thinks about public policy. And we haven't succeeded in overcoming that failure, I think.
But if I can add something here, that I think we have a political issue that Ricardo's talking about, and that's maybe we need to work with politicians about how they sell health, what they do in the health field, because it's only a few families that are touched by cardiovascular surgery, especially for children. So that's very rare. One of my nieces just had that, some serious cardiovascular surgery. But everybody is touched by the unavailability of drugs, the kind of poor treatment that people get in the typical government health services. So if a politician could improve those services and get credit for it, he can reach many more voters than he can reach by the occasional family touched by those rare surgeries. So helping politicians know how they could get credit for touching every family by helping them have the basic services that all of them need every year should be able to help them get the votes that they need to be reelected. So I think we may need some work on that side of things.
Yeah, making the political benefits of investment in a way that's pro-health more tangible.
So just one anecdote on that. The Chilean president who set out the HES reform 10 years ago was a socialist, an economist. He wanted to improve the health sector, didn't know exactly what to do. So he traveled around the country and went to the extreme south and visited a health center in the evening. And there were a few people sitting there, freezing. And he asked, "Hi, I'm a candidate for the presidency. My name is Ricardo Lagos. Could you please tell me what would you like your health system to do for you?" So one of the persons said, "Sir, I get here by horse. If there would be a place for me to attach, my horse outside, that would be very helpful." And the other one said, "We wait for hours and it's really cold. Could you bring us some heating?" Those were the answers. And his reaction was, "I can't believe what primitive expectations people have of their health system. It means that we have trained them to expect nothing."
Mhm.
So that's when he came up with the idea of establishing legal guarantees for access and for quality.
That's a great story. Okay, let's go to you. First, second row, please say who you are.
Thank you very much. That was a great discussion. Bob Fry from the Health Finance and Governance and Apt Associates. Interesting, didn't hear a lot about the introduction of new technology and whether you could say a bit about that and sort of advice that is given around the world, because you see these wonderful advertisements in the US and you see restricted technology introduction in Europe. So what's the advice to emerging developing countries? Thanks.
Should we take three? Dr. Lane?
Thanks very much. Ricardo, you may not know I come from Barbados.
You weren't there at the time, and
And it'd be nice to know that Barbados is one of the first countries after Mexico that introduced a tax on sugar-sweetened beverages because they're very concerned with the issue of obesity. I'm also very intrigued by your appreciation of what politicians do. Obviously, you were never a politician. But Ricardo, I really appreciated the essential message of what I took away was that it is one thing to set priorities, but that is not enough. There's a lot more to be done than that. I really appreciated your emphasis on the technical aspect of assessing priorities is really not the only answer. It's not the answer. But a couple of things I would ask your comment on. You spoke a lot of the 1993 report. And I've had many discussions with Phil and Dean Jameson about this, because the report says that those essential services with high externalities should be financed by the state, and those with low externalities should be financed privately. Later on, Dean would retract from that position. He and Phil had vigorous arguments about this, of which services should be financed by the state. And Dean's view now is that most of them should be financed by the state. So Phil was rabidly against that only those services with high externality content should be financed by the state, and the others progressively should not be financed by the state. The other point I was intrigued by your mention of Chile. And the question I'd put to you is this. It is true that the ratio has not changed, but the whole pot has gone up. Is that not a good thing? That the pot has gone up, and although the ratio has not changed, therefore those essential services are being provided to large numbers of persons. And another point I make is this. The ingredients that you mentioned are all terribly important, but you didn't mention the information services. And one of the things that we've come across is the difficulty in making these decisions, just a basic lack of information in health services. And our view is that is the area that countries spend least on, and that is understandable. And you know why? They spend least on it because information is that which is most likely to perturb the services. Therefore, they spend least on the information services. The last point I would ask is this. You mentioned a lot of the difficulty converting persons, the out-of-pocket expenditure. And one of the things I've heard a colleague of mine argument he would raise, out-of-pocket expenditure implies a certain degree of autonomy of the individual. And very individuals often do not like to lose that autonomy. Even although on the one hand, it might appear to be disadvantageous to them, they don't like to lose that autonomy. And somewhere we have to find a way of inducing them inducing them. That sounds terrible. Of building that into the equation, that autonomy loss that goes along with reduction in out-of-pocket expenditure. Phil wrote an interesting paper we often discuss. It's a pound of prevention is not worth a pound of cure.
Okay. One more. Paul, you're in the front.
Thank you. I'm Paul Eisenman, a consultant and a senior fellow at R4D. Question is, can I tempt any of the three of you to say anything about implications for the United States of what we've been talking about, and maybe even for current debates on universal or not really universal healthcare?
Yeah.
Can I actually add to that?
Yeah.
Question?
Go ahead.
I was going to ask something similar. Sure. And let me just also thank Amanda for hosting and thank Ricardo and Marty for your fantastic, really interesting discussions of this important issue. But I was thinking similarly, I was imagining a debate between Bernie Sanders and Phil Musgrove. And I was curious if you had any thoughts about how that might go. Single payer system in the US, what would Phil say to that? And maybe Donald Trump up there too, just to spice things up a bit.
Scary. Phil v. Bernie. Okay, let's let Maureen have the last word, and then we'll go back to our panelists.
I was going to say something about this in a slightly different way. I don't know how many of you remember the Oregon experiment, and that actually made a lot of sense because what they did was they started off by having physicians decide, and no one agreed, and they threw it out. And then they had the community, physicians, managers, insurance companies sit down and decide how you could prioritize. And you prioritize by age, by other factors that affected cost and affected when you could have the biggest impact. And I still think that this is one of the few times where you've seen an effort to ration care in a rational way. So I think that that's something, and I don't think we don't use that very often, but I think there's some benefit to it. And my second question has nothing to do with what anybody else asked, but it's a big issue in Latin America where health is a right in the Constitution, and forget about any ceilings or any budgets. I'm going to Miami, I'm getting my treatment, I'm sending the bill to the government, it goes to the judiciary, and the judiciary is consistently agreeing with the patients, and it's unaffordable. So this is another sort of piece of this that I think it sort of blows the basic package concept totally out of the water because there's a benefit package that is a human right.
Okay, Ricardo, do you want to?
Why don't we alternate? I'll try and answer one.
Okay, sure.
Thank you for your questions and comments. I wanted to try and address yours very quickly about new technology. I think that the biggest new technology that's creating a lot of problems and raising expectations is the arrival of biological drugs, which cure some diseases at an extremely high cost. So there's a biological drug now that can cure hepatitis C in a few months for good. It can cost tens of thousands or hundreds of thousands of dollars, but it cures it for good. There are biological drugs that can cure arthritis if taken early enough, but they cost in Latin America about $1,000 per person per month. The question is, how would those new technologies be assessed from the perspective of rational health priorities for a country? Since I've worked a little bit on that, I can say that some of the medical problems, which some of the patients who have conditions that can benefit from biologicals are very few. The frequency of those conditions is very low. So a low frequency times a very high cost results in a relatively small total cost. The budget impact of covering biologicals for many of these conditions is small. And therefore, I do expect that many countries setting up rationally their priorities will include biologicals, even though they cure a purely private health service, they do confer a lot of financial protection. And so I expect they will do that because of a small budget impact. And firms producing biologicals are exerting a lot of pressure on governments everywhere to achieve that. And I will comment very quickly and finally, and then I'll let Marty continue, on the financing of private services. I'm aware of the debate that existed at the time regarding what should a benefits package contain. And there was this World Bank economist called Jeffrey Hammer who said that people, not governments, should make a choice regarding what is their priority, and that no government should come and tell them priorities for this society are as follows. And Phil, at the time, kept arguing in favor of cost effectiveness as the sole technical criteria for setting priorities. I think that eventually Phil admitted that governments did not have the right to make decisions on behalf of people to decide all the contents of a benefits package, and that people's own personal priorities mattered and should be taken into account. But when it came to goods with high externalities and with pure public goods, cost effectiveness remained the valid criterion. So the idea that benefits packages can have private services that benefit the individual alone, makes sense from the perspective of people's preferences. And I think that that's the reason that lately they've been included. If you look at some of the recent approaches to policymaking, the objectives being pursued are three now. When I started my career, it was just improving health status, period. Then they added financial protection as a second one, and then they added customer satisfaction as the third. So when you take into account all three, and I think it makes sense, then your optimal benefits package will have inside private health goods or low cost.
Okay, I'll take a crack at a few more. I think I agree with George that the Chile whole pot rising is a good thing. So I agree with your comment there. So that's a good thing overall, that the total resources mobilized and the total resources going to those services that are within the package is a good thing, but it's still not prioritizing the services that are in the package. So I agree that it's a good thing. At the same time, it runs contrary to the notion that you're going to focus on the ones that are in the package. I also agree with you that lack of information is a critical problem, and that information is underinvested in. So that's why we don't have as much evidence as we need to be able to say definitively about lots of things that we know theoretically should work this way or another way, but we don't have the evidence that gives us the firm grounding that in practice it does deliver, or to what extent things deliver on what they do, so that there is a great value in having the information that tells you you're doing things right, you're doing things wrong, you're doing things pretty much right, because you're wasting a lot of resources on the things when you're not doing them right. And so a small investment that tells you change is very important. I think you're right again about the individual autonomy and as being important, and that we shouldn't focus on getting to zero on out-of-pocket spending, but we should focus on reducing it and achieving greater financial protection, so that people are not impoverished by how much they have to spend, nor are they prevented from using services because they just don't have the money to spend, but that the goal shouldn't be get to zero. And then on Paul's question about at least one implication for the U.S., of course, the recent, maybe it was even last week, things happen so quickly, that Trump's executive order about the low cost, low coverage kinds of policies being available. Obviously, that's an attempt to sabotage the Obamacare system and make it possible for the, in this case, it's not the informal sector, but the relatively young and healthy population to opt out of being in the solidarity that the great pool would make. So that's a clear attempt to do that. And then also on the question of the Bernie Sanders thing, of course, one of my claims is that we should not focus so much on contributory systems because of the cost and the convoluted nature of trying to figure out how to make everybody contribute when we have a contributory system to general government revenues. So let's use it. And that goes towards the single payer system. I'm sure Phil would have a critique of that, but I don't know what it is. So those are the ones I'll take, and I'll pass it over to you.
I mean, I wanted to say it's actually, if you think about priority setting in global health, we almost skipped a phase, right? Because the WDR started with interventions, right? But an intervention is made up of products and other kinds of inputs, right, and processes. But we didn't actually address this issue of products. It turns out to be pretty important, and it is the part of the budget that countries that have national health systems, for example, can actually do some priority setting on in a very easy and straightforward way. So before you start saying, okay, I'm going to look at, a clinical guideline for cardiovascular disease management or something like that, you could still be seeing, I'm buying a bunch of stuff right now. Let's see how well I'm doing on it. And I think your DRC example, I want to see that paper, because that is a very striking statistic that if I just purchased perhaps different medications, or if I bought them in a different way, I could have the costs of delivering the same services. That's a very important kind of first level priority setting exercise that almost any country in the world could do. I mean, there is a movement in many health systems to do health technology assessment, which is essentially cost effectiveness. They like to consider, there's extended cost effectiveness now, where we could look at financial protection, where we could look at equity as part of methods. But I think one of the lessons of Oregon or the ties or other systems that are have thought about this more is that there is a process and governance around the deciding of benefits, no matter if it's cost effectiveness or responsiveness or some other criteria on which we're taking decisions, but that it's an annual exercise, that it's an exercise that takes into account the fiscal envelope, and that it's an ongoing function of the health system to do that, to select systematically. So that's actually what the whole what's in and what's out is all about. On Phil versus Bernie, I think there's actually a really interesting issue of the Journal of Economic Perspectives that's out this week that actually looks at what is the value that insurers are adding in our system. And there are a couple systems like the US system. There's the Swiss and the Israelis, the Colombians, that have multiple insurers as administrators. And I would say the interesting thing about those systems is that many of them spend a lot more than average, and many spend much less. Obviously, the United States is a complete outlier. It's not like our system of competing insurers couldn't work better. Of course it could work better. So I don't know I don't think our main problem is that there are private insurers in the system. Our main problem is that the policy framework is a bit dysfunctional, right? We don't have, we need those massive subsidies, unfortunately, to enroll people that are not enrolled. I think states now understand that they're going to pay for that no matter what happens, right? If I don't insure someone ex ante, I'm going to pay for it in emergency rooms later, or I'm going to pay for it in mortality. And what's good news, I think, about the opioid emergency is that people seem to care if people die unnecessarily, which is something people say about the United States. Oh, you don't think health is a right, you don't care about what happens to other people. But I think you can see, actually, people care a lot. And they care in red states and they care in blue states. So hopefully we can get it together to fix our system in some way. And that is politically feasible, right? I mean, maybe, I don't know if getting rid of private insurance is going to be that way. Whether we'll be paying providers directly again, that brings its own big problems, as we know from Ghana and elsewhere. So with that, I'm looking for our events person. There's beverages, and you can, and snacks, thanks to Results for Development and the fund put together by Eleanor and her colleagues. So I invite you all to join us to celebrate the work of Phil and also Ricardo and Marty as great health economists and all of you. Thank you.